Remember it originated in China, probably in a wet market where animals were sold. And actually also the trade and the economy is suffered, which is also disrupting global food trade. But more specifically within the context of our food system, there seems to be a very strong relationship between diet, physical activity and COVID-19. For starters, we know now from the hospital and the case studies and the case series studies that people with obesity or type 2 diabetes are particularly prone to suffer and to have it in a serious form. It also, of course, targets the elderly in a disproportional amount. And obviously, with the nutrition deficiencies being present in elderly and even malnutrition occurring, this is very important for us as a community. And finally, as we already saw with the Mentimeter in the lobby, it impacts also our habitual diet and our physical activity. And we don't know what it will affect, how it will affect the future. And especially we are worried about the people from low socioeconomic classes. And obviously, COVID is here to stay. It's maybe not COVID, it may be another pandemic. We may have a vaccine maybe the next 2 years, but still we need to address this topic. And therefore we'd like to contribute to these discussions. And this today is the first exploration where we want to explore what's going on already in types of research, in both the clinical and metabolic, as well as the behavioral aspects. But we also want to know where, especially the JPI HDHL, Healthy Diet for a Healthy Life, needs to steer its research questions to, thinking already about the COVID situation, but also probably post-COVID situation. And that's also why we want to organize this webinar and like to have your input. So you're a scientist, but you're also funders, you're also health professionals, as we saw. So we're very curious to hear more from you on what we would need to do. And to start off, we'd like to give the floor to two keynote lecturers. There, after each lecture, there will be 5 minutes room for technical questions. So not for really a discussion yet, but at least, for clarification questions. Then I'll introduce you to the panel, which consists of people, for example, who already work in projects funded by JPI HDHL. And thereafter, obviously, the floor is to the panel and the audience for the discussions. And I will try to moderate this with help of my colleagues here in the ZonMW office. And we will have the chat open, so please use it. You can also respond to someone else's chat or comment. So this is another technical message. And if you would like to come to the central stage, which is in our case now digital, you can indicate this also with one of the buttons in your menu, in the top of your menu on the left. Let's bear with us. A final technical message. You are now in the room for the keynote lectures. After each lecture, we will leave, and we will leave also, that will be done automatically back to the lobby and then entering the panel discussion, for example, again. Like in a real life meeting, we need to walk in a digital way from room to room. But, this is also for us, first we use this software, so we are learning on the fly. But without further ado, I'd like to introduce to you the first keynote speaker, and that is Professor Christophe Matthijs. He is from the University Leuven, Catholic University Leuven, if I'm correct, from the Department of Clinical and Experimental Endocrinology, and especially an expert in diet and obesity. Christophe, the floor is yours.
Okay, thank you. I hope everybody can hear me, and I hope that everybody can see my screen. So I hope that is... Can anybody give me a sign, because I don't know? Can you see the screen?
It's okay, Christophe.
Thank you very much, Edith and Emily. Okay, first of all, I would like to put a kind of a disclaimer. I would like to tell that I'm not necessarily an expert in diet and COVID-19. I don't think there is really an expert already in the field there. So what I've tried to do in the context of potential funding and potential ideas, I've tried to kind of summarize what we know, what is the current advice that people try to give, that people try to publish, and so on, and what is the evidence behind it. I could make a presentation of hours and hours, so that is not possible. And that potentially a bit boring as well. So therefore, I focused on a few aspects. So let me first go back to what is really COVID-19 disease. Yeah, and as we all know, it is caused by a virus, the SARS-CoV-2 virus, which is one of the beta coronaviruses. Important here is that they these viruses are working in kind of collaboration with the angiotensin converting enzyme 2, or the ACE2. And ACE2 is especially important because it's really the functional receptor of the SARS-CoV-2, and so the COVID-19. So that's important to keep that in mind, because the ACE2 is also relevant in other diseases. Think about cardiovascular diseases, for example. Yeah. And so in that sense, where is the ACE2 enzyme present? Well, it's present in the lung, in the epithelial cells, the enterocytes as well of the small intestine. And it's mainly there in the endothelial cells where it will have an effect. So actually what is potentially happening, and it's some of the evidence that is available, it's not 100% crystal clear yet, but as you potentially all know, is that that you have this cytokine storm that is created. So the SARS-CoV-2 virus is entering the lung, where it introduces a cytokine storm, so huge inflammation. And what is kind of interesting is that the endothelium is also involved in it through the different, so the pathophysiology is through different mechanisms. As the first mechanism is a vascular leakage, yeah, and then a second, the coagulation is going to start, which is going to form these platelets, and then again an increase of inflammation. So you really have a huge storm, and this vascular leakage is potentially one of the origins of this edema happening in the lungs. So what you clearly can see is that inflammation and a huge, this cytokine storm and the inflammation storm is really happening. And that is, of course, one of the triggers that we have to keep in mind for the rest of the presentation. Now, what are the typical clinical characteristics of the COVID-19 disease? Is that frequent symptoms are fever, cough, and shortness of breath, most of the time at the hospital admission, not necessarily for everybody who has the virus. But what we also see is that things like headache, for example, nasal obstruction, cough, weakness, muscle pain, gustatory dysfunction, and sore throat, but also loss of smell is present. And that is most of the time when it's a mild or moderate disease. And so that's not necessarily at hospital admission. So we have to be careful as well in all the evidence that is there, or the lack of evidence that is there, that we have different phases of the disease. And so it is sometimes very difficult to really say from, okay, this is working on that or working on that aspect. So that is something we definitely have to keep in the back of our mind, especially if we think further in the context of research projects. And it's also what we see as well is the olfactory and gustatory dysfunction that is happening, and more or less, and based on pooled prevalences of different studies, in 50.2% of the patients. So meaning that if we talk about food or diet or dietary patterns, a lot of things are still involved, because gustatory dysfunction or olfactory dysfunction, of course, have an impact on how we eat or what we eat. Now, more important, of course, is the complications and the mortality. And what we really see is that the severe cases and the critical cases, they occur luckily in a smaller percentage. So the severe cases are in 14%, and the critical cases in 5%. And most of the time, it is expressed in acute respiratory distress syndrome. Of course, as you have seen 2 slides ago, within the potential mechanism, there it's very clear that it is mainly in the acute respiratory distress syndrome that is happening. Now, what we also see is that the COVID-19 is associated with an increased risk of cardiovascular complications. So it's not only that. Now, our moderator or chair mentioned it already, that the people who are affected have specific characteristics. So what we see, it's mainly at the older age. Yeah. And so if we look at it, we see the cases of more than 80 years, they have a case fatality rate of 14%, and it decreases. So what is really happening is that in the elderly of people of older age, they have a much higher chance to have to die from the COVID-19 disease. But important as well, what we mainly see is that the comorbidities are happening as well. So it is there that we see this, that people that are suffering already from one of these comorbidities, namely hypertension, cardiovascular diseases, diabetes, COPD, for example, or specific forms of cancer and chronic diseases, that they have a higher chance as well. Quite interesting is to see that, as mentioned by our chair, is obesity. But obesity was first not identified, and very simple, because in the first studies, when we were talking about in China, the waist circumference and BMI were not included in the patient characteristics. So it was only in a later phase that obesity was included as well as one of one of a comorbidity on the one hand, but also since the potential patient populations, which is of course quite interesting to see and quite relevant, of course, to take on board of that. Now, we are talking about older age. Now, what is happening, of course, at an older age? A lot of things are happening. Yeah, and one of the things that we definitely see in older age is malnutrition. Yeah, malnutrition is highly prevalent. I've just put some figures up here, and it depends from country to country, but it's more or less in that trend. It's in hospitals, it could be 30 to 40%, or even sometimes up to 50% in different geriatric wards. Now, what is my main remark? It's a relative figure, which is rather high, but if it's at your geriatric wards, it is still a small number of people in absolute figures. I find it more important to see that the malnutrition, risk for malnutrition and malnutrition as such in the community is, you could say, a relatively smaller, 10 to 15%, depending on how you measure it and so on. But of course, that is translated in absolute figures that it's a much bigger part of your population. Doesn't matter if it's Belgium or the Netherlands or any other country. And I think that is sometimes something that we tend to forget. It's of course a challenge to reach out to these different populations groups in the community. That is something that we have to take into account. And of course, what are the determinants of malnutrition? I mean, as you all know, the Manual project and the Eurodiet project of the JPI Healthy Diet, Healthy Life are working on in this population groups. But some of the malnutrition determinants of malnutrition are related to the concept of anorexia, of aging, of course, that is happening in the older age people. So it's a sensory decline, it's less dietary variety, it's combination of swallowing problems, polypharmacy, and as well here again, what we have is this low-grade inflammation, and of course the imbalanced gut microbiome that we see, and those all are determinants of malnutrition. And it's very difficult to say that one specific determinant is much more relevant than the other one. So it's more a multiple approach that needs to be targeted than just working on one specific determinant. So that is within the older age. And of course, what we see if we think about the COVID-19 disease is that we have to take into account what is actually happening when aging and the immune system. And I just took, and I'm not going to read, I suppose everybody can read and the slides are available later on. It's just what is happening, of course, related to the immune system. It's the immune decline. All different systems is decreasing, and I think that is really important to take that into account. And that's also the reason why older people are more vulnerable to these very acute exposures of specific viruses and who are going to target the immune system. And if we take the other big group then, and relevant group, is people with obesity, is that obesity here again is what we know is that it's highly related to other aspects. So there will be obesity is related to a respiratory dysfunction. Yeah, a lot of obese people with obesity are suffering from sleep apnea, for example, other respiratory dysfunctions, impaired mechanisms, impaired airway resistance as well. But what you have as well, once a patient with obesity is entering the ICU, for example, it's very difficult to ventilate these patients because a lot of the equipments are not foreseen for these type of patients. And of course, obesity is also related to the comorbidities like kidney disease and diabetes mellitus, which are multiplicator effects for vulnerable people within the context of the COVID-19. And if you then link, of course, they also have the metabolic risks, hypertension, prediabetes, insulin resistance, and dyslipidemia. And so all these factors are multiplying the effect or the vulnerability of these type of patients in the context of COVID-19. And I think in that way, it's really important to keep that in the back of our mind. Now, actually what is happening, so actually what we see in this COVID-19 disease is quite interesting, is that actually our nutritional status is very relevant. So on the left-hand side, what you can see is that obesity is changing our expression of the different immune cells. And the changing of the different expression of the immune cells, and due to this low-grade chronic inflammation, is what you see is that we have an impaired protective immunity system through the different mechanisms of the macrophage, the cytokines that are produced, and the different actions of the different cells that are working. But also, if we look at malnutrition, and in this context, malnutrition is mainly undernutrition, adult undernutrition, hospital malnutrition, and so on within people of older age. And so what you have here is that you have, on the one hand, the immunity deficiency, but also what is happening is this low-grade chronic inflammation. And that what you can see is the impaired protective immunity again. So both what we see here is that both sides of the distribution, obesity and malnutrition in the case of undernutrition, because you could consider obesity as well as a form of malnutrition, but that both sides of the curve of our nutritional status are having effect on the immune system. And that is, of course, something that we have to think of and that we have to be relevant. Now, one of the first things that we could see and what was happening in, and I'm now taking not scientific evidence, but anecdotal evidence, where you could see that in Belgium, when the lockdown was installed on the 15th of March, all of a sudden on the social media and all this kind of stuff, you had all kind of anti-inflammatory foods, and we all had to eat specific food products, food supplements, especially food supplements we had to eat, and so on. Now, the big question here is, of course, what is true, what is relevant, what does work, what does not work. And that is a little bit what I will try to go through. I'm not able to tackle every nutrient or food item, of course, but I've took a few of them that are currently under debate and where there's a lot of discussion of. Now, one of them is the vitamin D. Now, what we know is vitamin D has been, vitamin D receptors have been identified on the different immune cells and that the active and the immune system can synthesize the active form of vitamin D. And in that way, it can have an important effect on some of the immune regulatory aspects. And as well, there has been seen an inverse association between the active component, the serum 25-hydroxyvitamin D, and respiratory tract infections. especially what is mainly important is that some of the meta-analyses have shown that vitamin D supplementation can reduce the risk of the respiratory tract infections. Now, one of the things that we have to keep in mind, and was already slightly mentioned by our chair, and I'm not sure if really everybody captured it, but it's the concept of low vitamin D status. Yeah. And I think that is something that we have to take in the back of our mind, that both people of older age and obese people have problems with the low vitamin D status. Yeah. Now, does that mean that we have to start supplementing everybody? Well, we have to be very careful on the one hand. So there is currently no studies that really have already results on vitamin D results and COVID-19 infections. There is, and on the last bullet of this slide here, what you can see, there is in the UK, the Confidence UK study, which is really investigating how diet and lifestyle factors may influence the transmission of SARS-CoV-2, yeah, and especially then as well on the vitamin D aspect will be looked at. Yeah, and so there is conflicting results. Yeah, and so mentioned on the previous slide, you could see that vitamin D is really having an effect on the upper gastric tract, while here what you can see is that on some extrapolated from randomized trials that there is no really relationship. Yeah, and so there is a little bit the discussion of the chicken and the egg. Do we first have to start supplementation to increase the vitamin D levels? Yeah, and if we increase these vitamin D levels, will we have then enough vitamin D, for example, to have a protective role in the context of the upper respiratory tract infections? Or do we really have to give higher levels of vitamin D, for example, above the current levels that we have? So that is a little bit the discussion that we currently have and which is currently ongoing. Yeah. Oh, this is the wrong slide. Sorry. Another one that has been had discussions is selenium. And what you see in this presentation here is some results from China. Yeah, and where you could see that people or cities that have a higher selenium content, and here it was hair as used as marker. Yeah, and we can discuss, of course, as well about the relevance of the markers. Status markers are still important, and there is a lot of discussion about the use of the relevant status markers. Yeah, what you can see here is that if people or cities with higher selenium status, yeah, that, for example, that you can have that you have a higher cure rate. Yeah. Of course, what is not clear from this study, and is also mentioned by the authors, yeah, what is not clear from this study is that the level already reached, that is an optimal level or a healthy level of selenium status or not. And that is something that we still have kind of debate. And a lot of the discussion of the debate was already going on as well in Belgium, in Europe, sorry, regarding selenium, based on some preliminary associations and ecological ideas. For example, what you could see is that, for example, in Finland, the infection rate was much lower than, for example, compared to Belgium. And in Finland, they have the tradition of using fertilizers fortified with selenium. And that was one of the ideas where, okay, if we kind of, that means that the populations in Finland have a higher selenium status compared, for example, to the Belgium situation. And is it just that simple or not? That is something that we cannot answer for the moment. And that is one of the questions that, of course, are still ongoing. So selenium is another one. Another one is that you could see is the use of omega-3 fatty acids, in this case, the EPA and DSH, for example. What you see here is this kind of a summary of the findings of one publication. Yeah, and there you could clearly see that the EPA and DHA have the anti-inflammatory properties. Yeah, but there is a small remark. What we see here on the positive aspects, so there is a lower length of intensive care, for example, which is really huge cost reduction that you can see. We have a reduction of cause mortality. Yeah, but the main remark here is that we are talking about enteral and parental feeding. Yeah, so we have to take that into the back of our minds, of course, when we use these data. And that doesn't mean that we can just generalize and that we now immediately have to foresee everybody with higher amounts of EPA and DHA, because this is a study really in the context of ARDS and the acute respiratory disease syndrome as the first manifestation of the COVID-19.
Christophe, can I ask you?
Yeah.
You're doing very well, but you can speed up a little bit, perhaps.
Okay.
I'm just noting the time.
Okay. I will skip this slide because this is more or less the same story that I'm going to tell. Yeah, it's a herbal medicine, and it's in the Chinese medicine principles. So I skip this. Yeah. What is really important, what I want to mention here, is that what we are confronted with for the moment is that this simple paradigm of intake status health. Yeah. And a lot of things are known in the nutrition field, and sometimes a lot of things are only known about the intake. Sometimes things are known about the status, but most of the time we do not necessarily know what is really to the functional or clinical outcomes. And that is something that we really have to keep in the back of our mind of the whole discussions, but also the discussions for further funding. Yeah. If we are talking about status, for example, different micronutrients have come up. It's very difficult for me to find, why is this all jumping back to vitamin D? I'm sorry for that. It's very difficult to find figures about, for example, the status markers. Yeah, I could find something on vitamin D, but not in every country, for example. This is just one result where you can see that based on the different cutoffs, the vitamin D status is not necessarily optimal everywhere. Something similar we can find for people with suffering from obesity. Yeah, but it's fragmental. Yeah, and so if we think of the concept of the double burden of malnutrition at the individual level, a lot of data as such is missing. And that is challenging because you can say, okay, we need to have all this information, but it's also a matter of collection. So we need better markers of intake, better markers of status, especially as well on data collection point of view. Yeah. In sake of time, I will skip this because this is really treatment and vitamin C. There is a lot of discussion about the vitamin C, and there is no final conclusion. Here again, on rehabilitation, one of the things that we definitely have to take into account is that once people have been suffering or had COVID-19 disease, then they have to come back into the normal life and normal diet. And how do we do that? This is and I missed the reference, sorry, it's an Aspen guideline. That is something very question for the moment. It's an open question, and the guidelines are mainly based on the COPD guidelines. What we do currently as well in our hospital is we use these guidelines on the previous slide, but we also work on the gastrointestinal tract optimization. Yeah, and we use the different fibers that are mainly based production on the butyrate production, because some preliminary results have shown that it could be beneficial to work on the butyrate production, and so optimizing the gut microbiome. And as well, vitamin D3 seems to have, based on a small study, seems to have a positive effect as well on the lung tissue development. Now, just to finalize, Mrs. Chairman, is some clinical observations. Is what we have seen is that a lot of new diagnosed type 2 diabetes, and there is a discussion. We do not know that if they were not diagnosed, especially in elderly, but some results or some papers have already shown as well that obesity or people suffering from obesity can, and when the COVID-19 disease are suffering from COVID-19 disease at the same time, can introduce type 2 diabetes. So again, you see a bi-directional effect that is going on. And based on some very preliminary results, if we use the guidelines for treatment, what we see is a very rapid weight gain. And so that is something that we, of course, have to keep in the back of our mind. So my take-home messages: the vulnerable groups are definitely the elderly, persons with at least one comorbidity, and especially as well here, the groups of people suffering from obesity. What do we know about really the nutritional status of the different risk groups? Well, hardly anything, or definitely we need to know something more. Can we treat COVID-19 with food components? Well, I have some very interesting results seen, but it's still a question mark. And in elderly, there are people mentioning that we can use vitamin C, vitamin D, zinc, selenium at a much higher doses than the optimal traditional healthy diet. And that is something that we have to can look into it. Final question: can we optimize the nutritional state of our populations? I would say yes, very simple, but there is a yes but for those who like Little Britain. Vicky Pollard will say yes, but I think that is still a very difficult question, because more or less we know what we should eat, but nobody's eating it. Thank you very much for your attention.
Thank you very much, Christophe, Professor Matthijs. I think you illustrated very well the relevance of nutritional status in COVID-19. And it's also good that you alluded both to the clinical and individual aspects as well as the public health aspects. This paper is now open for clarification questions only. The other things we will move to the panel discussion. Are there any questions from the audience? In the chat, we have it open. If you can't see the balloon, it's behind the 3 dots on the left-hand side of your screen. I saw questions from Laura Fernandez, the chairperson of the SHEP. She will be in the panel. I think, Laura, maybe a clarification question. Your question was the severity of COVID-19. To what extent is it related to malnutrition? You showed some results, Christophe, but is it really clear already? That was the question.
Yeah, well, it's what we can in the context of what we see from the figures is that people that are diagnosed as malnourished have a higher chance, or the case fatality rate is higher, and that is but that is strongly related with age. So it's sometimes very difficult to make the clear distinction what is really the biggest marker. So for simplicity reasons, you could say from its malnutrition. On the other hand, you could say simplicity reasons it's age. So it's very difficult, of course, because the correlation between both are very strong. But what we see in the context of in the context of case fatality rates, and from as far as I know the studies, it's both when there is, especially these age as such is not the key determinant, but it's mainly when these comorbidities, meaning malnutrition, for example, in the wide definition of malnutrition, on the one hand obesity, on the other hand the undernutrition, then the case fatality rate is increasing steeply.
Yeah. I'm looking with one eye on the chat. A question from Sue Fairweather Tate. Is it true that a positive effect of vitamin D was only observed in subjects with low baseline levels of hydroxy vitamin D?
Yeah, okay. That is the whole discussion about it. So do we have to optimize the status, or, and then we have see benefit effect, or once we have a beneficial effect, additional vitamin D, would that have an effect or not? And that is a whole discussion about vitamin D, but that's also, as far as I know, relevant for other studies. And the discussion there, of course, and that is just recently published in the UK. I think it was yesterday published in the Journal of Nutrition, where they had a plea for different micronutrient recommendations for people older than 65. Yeah. So there, of course, you have the discussion of recommendations and
yeah, clear. I think in view of time, there are some other questions, but I can see that from the nature, I think they can come back in the panel discussion. Also a question on the herbal medicine. You skipped them just because I asked you to speed a little bit up, but we can come back to that in the panel discussion. I'd now like to give the floor to the second keynote of today. Professor Emily de Vet. She's from Wageningen University and professor in consumption and healthy lifestyle. Without further ado, Emily, please go ahead.
Thank you.
And you introduced your topic yourself, right?
Yes. Nice.
You can share the screen.
Yeah. Yes. Share screen. Application. Yes, I think.
Yes, it's coming, I think. Yes, we see something. Yeah.
And if it's correct, you have the full screen now? Is it?
Yeah, we have the full screen there. Yeah.
Yes. Well, thank you for the opportunity to present here on the relation between coronavirus disease and healthy lifestyles. And Christoph was already mentioning the double burden of malnutrition. I also labeled my title as Double Trouble, but I will focus a bit more on the socio-economical and behavioral aspects of COVID-19 disease. So where Christoph was mentioning particularly the relation between how diet, nutrition, and specifically also obesity affect the course of COVID-19, I would like to start with reversing that relation and explain a little bit on the work that has been done on how and for whom coronavirus disease has affected particular lifestyle behaviors. And then ultimately, I would also spend some time on discussing how can we then support a healthy lifestyle. Well, first of all, a disclaimer, because there's still, and that's of course very logic in a way, there's only limited literature available that has been gone through the process of peer reviewing. So the results that I will present from studies are first indication, and it's what is currently the state of the art, but the state of the art needs to be expanded with future studies and needs to be taken with some caution. Nevertheless, some studies appeared in the last few weeks on the effects that corona measures had on lifestyles. And that included different types of measures, not only lockdown, but also working from home, social distancing. How is the entire package of measures affecting how people eat, how much they exercise, what does it mean to sleep? And I will explain a few of these studies. First of all, this is one of the recent studies. It's been published only a few weeks ago. It's a multi-country sample. Most studies focus on one country specifically. I will also give some examples of those. But this is a large cross-sectional survey that was taken in April among different countries. Overall, this sample was rather highly educated. More than half of the participants had a master or doctorate degree, and also a rather young sample. And in this specific paper, there was it was specifically analyzed what does these home confinement measures mean for physical activity, measured with the short form IPAC, and on diet behavior, which was measured with a very short questionnaire that was specifically developed for lockdown situation. What the study was showing was that overall in this multi-country sample across countries, there was a decline in physical activity, whether it was in vigorous intensity activity, moderate intensity, walking overall, and at the same time an increase in the sedentary time. So more people spend more hours sitting per day. Also in diet indicators or eating behavior indicators, across different indicators, there was a significant deterioration, so to say. So people were less likely to have and to eat unhealthy foods during the confinement than before the confinement. They more often felt themselves being out of control for eating, more likely to have snacks between meals or snacks at later points in time in the evening. One positive effect that was noted was that during that people reported that during the confinement they engaged less in binge drinking alcohol. So that was a positive change in a positive direction. And also in the number of meals that people were having per day, there was an increase in frequency reported before and during home confinement. What was interesting is that overall, you saw in this specific study that there is no negative impact on diet and physical activity, but it was a very, well, robust measure. No fine-grained analysis was taking place on intake, neither was there specific analysis of subgroups. Some studies did look into that, and I will also want to show you some of these results. This is also, again, a rather recent study that appeared from a survey that took place after 7 weeks of lockdown in an Italian sample, largely female sample, I should say. But in this specific study, there was more information gathered on adherence to specific aspects of Mediterranean diet, also on daily consumption of certain unhealthy foods, and also number of meals per day, and some lifestyle behaviors that go beyond diet alone. And there it was a bit more nuanced. It was not only a negative effect on lifestyles reported. What they noticed was that the number of people who quit smoking reduced during this during the course of the public health crisis. That the hours spent in sleep was increased, so more people spent an average of 7 to 9 hours in sleep during the night. In physical activity, it appeared that people remained rather constant in their amount of exercise. So the proportion of people who were training remained constant, and the people who were not training remained constant. But there was an increase in physical activity among those who did already engage in training before the crisis occurred. And about half reported weight gain. And more specifically, in this analysis of weight gain and dietary change, it was found that more than half of the people reported a change in appetite, where this was more often related to a sense of having an increase in appetite rather than a lowered appetite. Again, in this entire group, diet quality wasn't affected much, but what was found was that a BMI, so a higher BMI, was negatively associated with diet quality. I think that sort of replicates what is commonly found. But if they looked into the changes that were perceived by the participants, then it was also found that those with a higher BMI more strongly reported this increase in appetite, and also more strongly reported an increase in the consumption of several unhealthy junk foods. So this, whereas, as Christoph was mentioning, there is a clear link between suffering from obesity and a severe course of COVID, it seems as if there's also some inverse relation in the way that maybe obese participants, patients, are also experiencing a stronger impact of the current measures and the public health crisis on their lifestyle behaviors. So this is a US study that again is still in press, but also fairly recent, that specifically looked into patients in an obesity clinic who were following a treatment, whether it was a weight loss treatment or a bariatric surgery, in 2 weeks after lockdown. And what they noticed was that specifically in this sample, there was a very steep increase in sense of anxiety, increases in depression, and both those are, again, also related in turn with, have been documented in the past in having a relation with other types of dietary behaviors and lifestyle behaviors. So the participants in this study reported a struggle with achieving their weight loss, reported less exercise time, and when they were engaging in exercise, they reported less intense exercise. There was an increase in stockpiling of food observed, and particularly stress-induced eating was reported in this specific sample. This was only one study that I found that was specifically looking into children and adolescents in Europe, in northern Italy. There, it was also observed that specifically for these children, negative changes were observed, that their unhealthy food intake increased, time spent in sports activities decreased and screen time increased. Although at the same time, as was found in the previous study that was overall looking into population level changes, it seemed that sleep time increased. There was no change in reported vegetable intake and a slightly marginal, it was not significant, increase in fruit intake. So there might be also some positive changes observed in that specific group. And as a final study in describing how all kinds of measures to control the epidemic has affected lifestyle behaviors, I want to present some data, and this is really preliminary data. They are not reported yet, so they haven't gone through this peer review process, but I think they're very relevant. This is a study that was conducted in the Netherlands. It was initiated by the Netherlands Nutrition Center. Data were collected by a flycatcher panel. And in this sample, which is rather representative in terms of educational level, so a low to moderate education level and a smaller proportion of highly educated participants, there was a comparison made possible between different BMI groups. And although overall there was no report in change, or for the majority of participants, they reported no strong changes in the healthiness of their diet or in the amount of food that they ate. There were quite some, I think, striking differences between different BMI groups observed. So, and this is really preliminary. And we are in the process of writing this down into a publication. But overweight and obese, if we compare these groups to healthy weight individuals, they more often reported that they had difficulties in eating healthy, that they were more likely to eat larger amounts, so more food than they would do in normal times. Also more likely to eat unhealthier than to eat similar. And it should be noted that for the overweight subgroup in this sample, they also reported to eat more healthy foods than compared to other groups. So that's an interesting observation, I think, that needs further fine-grained analysis. But both overweight and obese reported a higher frequency of unhealthy takeaway delivery foods. And then most notably, it was getting pizza delivered and the Dutch frituur that was observed. All these analyses were corrected for sex, for age, and level of education. For level of education, there were some additional independent effects, but they were a bit mixed. But what was also found was that low educated, so that participants with a lower educational level did more frequently groceries, but also had a more frequent reporting of unhealthy takeaway. So what this suggests is if we would look into these maybe generic overall samples, that the impact of confinement, you could say, well, it's hard to say that they have a very strong impact. They might seem limited, but you could also draw the conclusions from these, even though it's a small sample of studies, that they point to the same direction, that at-risk groups may be affected more. So it might mean that those who have already an unhealthy lifestyle may become unhealthier, and those who are adhering to some healthy lifestyle behaviors will find the opportunity to become healthier, right? Those who were engaging in physical activity were getting more training, for instance. What is still missing, I think, is that in these studies, there's a limited attention for the interrelatedness of all these different lifestyle behaviors. We know that stress has an impact on sleep, sleep has an impact on diet, physical activity will positively impact sleep. So there are all kinds of interconnections that haven't been investigated so far. So there's limited attention to clustering, but also a limited attention to what is underlying these observations. And then this is what I would like to pay more attention to in the second part of my presentation. So there are already some observations how the living environment and socioeconomic position, for instance, have a strong influence on lifestyle behaviors, but that might also impact the course of Corona, for instance. So this is just some figures from the US. But we across the globe, I think there's a clear link between poverty, obesity, but also access to healthy and unhealthy foods. So here you see that where in the areas in the US where people have a lower income, where more people have no access to a car, no access to a supermarket store, those are also the areas where adult obesity is more prevalent. And in the left under map, there's a heat map of the density of fast food restaurants. You also see that in these areas, the exposure to unhealthy food environments is more frequent. This is not something that is just related to US samples. I will present two studies from the Netherlands. This is a study that's being published about 2 years ago, which focused on how do food environments look like in school surroundings. That was actually showing that if a school was positioned in an area with, on average, a lower socioeconomic space, socioeconomic position, the school food environment surrounding that school was unhealthier as well. And this is a study that has just been recently published for my own group, where we also use geographical data and combine those with survey data among Dutch adults. And we know based on their postal code how many food outlets and fast food outlets there were in their surrounding. And when people were living in an area with a lower income, the exposure to fast food outlets in within 400 meters within their postal code area was higher. We also found that when this fast food exposure was higher, people had stronger perceptions about unhealthy eating, that unhealthy eating would be normal, that in turn influenced their fast food consumption. So this food environment is related to both socioeconomic circumstances as well as to eating behavior. And this is particularly relevant in the current situation. There's this, also a very recent article being presented that refers to the syndemic pandemic. And syndemic is a term that refers to the situation where risk factors and comorbidities are interacting, are intertwined and cumulative. And in that sense, also adversely increasing or synergistically increasing disease burden and increasing negative effects. So in a situation where we already know that there are large inequalities in social conditions and socioeconomic circumstances, as well as in non-communicable diseases that are in turn influencing the course of COVID. This is a complex interrelation of a situation that is really affecting public health largely for specific subgroups in society. And these are some data that they present in their specific analysis of this syndemic pandemic, where they refer to a situation in Spain that the rate of COVID infections is 6 to 7 times higher in the most deprived areas in Spain. Also in disadvantaged US counties, there was a steep increase in the risk of death from COVID that was related to the disadvantaged, the low income of the neighborhoods. Also, a higher prevalence among different ethnic groups was observed in both in the UK as well as in the US. And they argue, these authors, and I think that's a really important point, that we need to look into the intersectionality of how different race, socioeconomic, demographic factors are working together and contributing to health outcomes in relation to comorbidities, but also in relation to COVID. This is also important, I think, not only when we look into how social determinants are affecting health outcomes, but also in the other way around. It is foreseen that the current COVID situation is causing a large economic crisis, that it may have very large effects on employment rates, that people will suffer from reduces in their income. And it's also been argued that especially for those maybe families who are already living in deprived neighborhoods under difficult circumstances, that schools closing, for instance, might have a larger effect on educational attainment of their children, which would maybe suggests that this current situation may lead to even a lower socioeconomic position and further worsening of the social conditions that then in turn also affect lifestyle behaviors. So to wrap up, I think that we see that in different areas, whether it's in economic analysis or behavioral analysis or public health and population health issues, they're all different elements that sort of are studied separately. And I think that we do have little bits of the puzzle, but that we need to combine these insights and to get a better view of how the different factors contributing to this major public health issue are interacting and are intertwined over time. So more specifically for the effect of corona on actual eating behavior, diet, and other lifestyle behaviors, the focus of the studies that have been presented now focus specifically on the home confinement, on working from home. But at this point in time, there is again a sort of a relief in some of these rules and the measures. And then it's important to also see, okay, what is then happening to lifestyle behaviors? How does it have affected maybe breaking unwanted habits, or have we formed new unhealthy habits or formed healthy habits? So how is it? How is the behavior change that's being observed in some group now being persistent over time? So there's a desperate need for more longer-term studies on lifestyle that grasp these complex interrelations and pay attention to intersectionality in relation not only to the pandemic but to syndemic interactions. And I would argue that that would require an aggregation of all kinds of sorts of data from different countries, different indicators of behaviors and lifestyle, different measures, but also different levels, focusing either on what is happening at the individual level as well as on population level statistics. It also, I think, and this is something that was already an issue, right? How can we develop effective interventions and policies that we support people to engage in healthy lifestyles? I think it's becoming even more urgent in the current situation. And it's important that there is support for those who are overweight and obese in prevention and managing the course of COVID-19, for instance, through weight loss and studying the effects as well. But in addition to these more individual-focused behavior change interventions, there's also a need definitely to improve the structural condition, to focus and keep on focusing on how can we decrease the gap that exists currently between lower and higher socioeconomic groups, and that there is particular attention needed for the creation of healthy living environments that affect both behaviors, socioeconomic impacts on the outcomes of several health problems. Also, in this sense, it's important to combine individual level and population level approaches to improve healthy lifestyles. And this is what I want to leave it to. Thank you for your attention.
Thank you very much, Emily. At the moment, I get signals that some of our audience is already present in the panel. So we suggest we all leave now. We move to the panel. And then some questions for Emily can also be addressed there. Otherwise, we lose some people. They can go to the panel, but they could not go back to us. So that's why. Okay.
Yeah.
Thank you. See you in the panel.
Yeah.
Twins. So yeah, it's adding a lot of things. I have to be honest, I don't have a just simple answer to your question, but I find
that's good.
I find it really relevant. And the thing is as well is that we have to take into account that a lot of nutrition research has been done, because what you're mentioning now is mild, moderate symptoms. And we are hardly able to identify in our research what is mild, moderate. I mean, if we do symptoms or we do studies, we go to the extreme ends. So people that are not mentally performing anymore or are completely dysregulated from a metabolic point of view, and then we start working on it. To see mild changes, I think that is very difficult. There was a very nice paper, and that was originally written in the context of the EFSA health claims, where they have kind of, they call it kind of a health balloon, and where you could say from, if you go to the extreme ends, it's very easy to show evidence. But if you want to show mild improvements, what is really the effect on the clinical outcome?
Yeah.
And I think that is something where we have to keep in the back of our mind, or we have to think of new ways of research on that aspect. And I think that is something that we have to
good
take
biomarkers, sensitive biomarkers, etc. Yes. Okay, thank you. I'd like to continue with a question put forward by Nathalie Delzen related to both presentations. She says, in view of the data on vitamin D, should we consider light and sun exposure as a factor in consideration? And this relates to vitamin D, but this also relates to physical activity. Jeroen Lakerveld, maybe I can give you the floor to reflect a little bit on this. You are a panel member, and I know you from sedentary behavior, etc. So not being in outside and getting vitamin D. So I thought you might have an idea about this.
So I do not know a lot about vitamin D, but I do know a little bit about being outside and active travel, for instance. And I know that during lockdown and during these confinement measures, the use of public space changed considerably. In many countries, such as the Netherlands, we were actually still allowed to go outside. And what happened also in many cities is that transport changed towards more active transport. This means bicycling and walking, which also enables more sunlight to enter your face and your skin, right? And this is this change in public space has gone so fast, and it hasn't been able to be implemented otherwise. So it needed this pandemic, so to speak, to really change. And the question remains as to will it be structural, and how can we make sure that it will be structural?
Yeah. What do you think about that? Because that's also, of great interest, also from environment point of view, right? We now see this, and not very few CO2, and that kind of stuff. And now we start here in the Netherlands still opening up again. I see a lot of traffic again on the highways.
Indeed, yeah. So there are indeed like the good side effects of this change in public space, but there are also big drivers and systems that want to go back to the old system, and there is like economic drivers also for the large companies, and but there are also indications that as many people are able and are working from home, they actually started to appreciate it, and they and I think also in the coming years there will be a change in the way we transport and we go to work. We do not go to work.
Yeah, exactly. Going back to normal means really normal. I'd like to ask a question to Wolfgang Arends, but now he disappeared from my screen again. Hello, Wolfgang. Bremen, come in, please. No. Okay, I understand he has problems with his connection. Then maybe I'd like to, Laura, I'd like to talk to you later. Is that okay? Because it's more on the communication from what we have been discussing. So I'll come back to you. Quirijn, can you elaborate a little bit? You already indicated a little bit more, on your own work, perhaps with the microbiota, which relevant research is currently taking place. But can you also look a little bit to the future, having heard these presentations and knowing this? What really is high on your agenda?
So high my agenda is so. Yeah, that's interventions. So what Christoph showed, some interventions like zinc, selenium, but also maybe other food supplements, probiotics. So these are all very interesting interventions. And but as I just said, so I would really want to make a case that we do need studies for way, give different arms relevant outcome parameters, and then you can really bring the field forward. So I think that's also needed with possible interventions like zinc, etc.
Yeah. I see Wolfgang. Wolfgang, welcome. I'm glad because you go in and out of the room. Can I give you the floor then? You know, the panel. You're a member of the panel, so perhaps you know which relevant research is currently taking place from your point of view, and what would be on your list on the highest priority for the forthcoming period.
So I very much hope I hope you can hear me now. And
yes, we can hear you and we can see you. Oh, not anymore. Maybe you can put your video off. That makes it usually more stable. Oh, that is really a pity.
Oh.
Then I'd like to turn to Laura first, if you don't mind. Laura, you have some different questions from my side. How can we ensure that people get the right messages? Especially in this time, we heard a little bit about the confusion of the hydroxychloroquine discussion. The papers which were published in Lancet and New England, which were probably based on fake data. We heard also from Christoph all the things in the media about immune boosting foods, of which sometimes there is evidence, but many times there is not. So how do you? What is your take on this?
Yeah, thank you very much, Edith. Yeah, as you think, I mean, just a very quick word. What we do is we turn complex food and health information or food and health science into easy to digest information for the public, for the general public. And our aim is really to make a difference because, of course, there is ongoing research, but the translation of that research into a general or lay language is not always done. I know that from the Joint Programming Initiative, Healthy Diet and Healthy Lifestyle, we are putting a lot of efforts and more efforts, I would say, will be put in the future to step up the dissemination of those results to the relevant target audiences and stakeholders. So, yeah, going back to COVID, unfortunately, this information about the coronavirus is mutating and spreading even faster than the outbreak itself, if I may say.
Yeah.
And as said, it is very important that we keep making the effort to bring the relevant scientific messages to the public. In terms of what we can do, we need to instill critical thinking into the minds of people and make them reflect and seek reliable and credible sources of information. And maybe they could follow 3 tips. The first one is watch out for highly exaggerated language or high use of emotional language. Things like, this is a breakthrough, is revolutionary, is the first ever. Of course, it can happen in science, but it should trigger some skepticism, maybe, and some further digging. The second one would be look for conspiracy theories. That is also proliferating, let's say, in particularly the online space and cyberspace, and getting into people, which because of the different opinions and information that they find, they end up losing faith in information altogether, which is really the worst situation possible. So when you see someone saying, oh, this is the secret that nobody told you about, or things like that, again, a healthy dose of skepticism. And the third one is really read beyond the headlines and check the source, check who is the author or who is the organization issuing that information, look for reputable, verified, trusted sources that can be international organizations, national authorities, governments, certified websites that have a trust seal, but also reputed organizations from healthcare professionals like the European Federation of Associations of Dietitians, British Nutrition Foundation, the Fooding Centrum, UFIC, of course, the British Dietetic Association, and many others. And those organizations should be working together to pass on coherent messages that reach hopefully especially the most vulnerable populations. And we have heard, I mean, how important it is because the comorbidities have a direct impact on the outcome and mortality of the disease. So I would say, in a nutshell, that would be the main messages for people to apply.
Yes. I'll come back to you later. I first like to turn to Emily.
Can I,
Emily, based on your question. Oh, sorry. Go ahead. Please go. Yeah. Who was it?
Yeah, I just want to add something both for Laura and Emily, if I may. So in that sense, is that okay? Those are kind of practical tips, tricks, but do we really know how to communicate to people?
Well.
Laura, I think there is quite a consistent base of science on science communication that can help craft the communications the best way possible. What is important is to rely on communication experts that know how to do the job, and they should be working with the healthcare professionals and scientists to get the facts right and straight. So I would say, yeah, the knowledge is there. We need to apply it, and scientists should rely on those experts, communication experts, to do the job.
Yeah, but I'm just, if I may, Edith, but because we've been talking about phenotyping, genotyping, and so on. But according to me, you can phenotype as well people based on the communication or accepting communication.
Yeah. Yeah.
But
that's important for treatment, obviously. Yes, that's true.
and I would say also, I mean, maybe Christophe, to your point, we should teach scientists, because we all have an individual responsibility to step up our game, and scientific experts should be out there where the conversation happens as well, and should learn how to do that communication. They should receive training in communicating their scientific messages so that they are understood and not misinterpreted. And I know that there are very good examples of scientists that are doing a great job in social media, trying to counter the misinformation. So we need many voices, we need organizations, we need individuals that work together, hopefully, to achieve the result.
Yeah. May I add something to that?
Yes. Go ahead, Emily. Yes, of course.
Because I think that also relating to the question, Christophe, is that I think too often still think of communication as something that is one directional. That it is we as scientists, we compile a message, and that is sort of the truth, and then we send it out to the audience, to the public. I think that there is also for scientists a role to listen and to have a dialogue with society. What are the questions? What are the struggles that people are living with, and how should that inform our communication strategy? So I would be an advocate of, for a dialogue rather than sending messages to audiences and, waiting whether or not they will be accept this message, because there's more to it than just acceptance of a message. There's more if you want to have behavior change. Yeah.
Can I continue? Thank you, Emily, for this addition. I agree. Can I continue with a question from one of the audience? Roberta Marcella. Gender. What is the role of gender? or sex. Let's not go into this detail. Studies should be focused also to evaluate how much different in response to diet or different lifestyle behavior. In your question, the behavior, social roles between genders may contribute to these differences. I mean, COVID is more often found in men than in women. But obviously, women have their vulnerable periods in life, also from physiology and metabolic point of view. So, how do you see this from a behavioral point of view? I think in general we see that the women tend to eat more healthy, for example, but obviously not all. What is your take on that?
I agree that there should be more attention for gender, and if you look into the studies that have been done on behavior changes during different measures, that women tend to respond more. So the samples, women are usually overrepresented in these studies on diet and lifestyle. So I think that there is limited knowledge at this point in time. I think that if we would look into more from a socio-economical point of view, there are some studies that's not necessarily related to health or to behavior change, but it suggests that women might be affected more by the higher unemployment rates, by lower incomes that have a more impact of the measure, so that they spend more time in caring for their children. So from that perspective, there is reason to believe that there is that there are intersectional relations between gender, low income, education, that will eventually have an impact on the long term as well. But on the health side, I think there's much more evidence in this.
Yeah, I think so, but I completely agree. The behavior side is a little bit, we need more attention for that. Wolfgang, can you hear me? I'll try it again. I saw you and you disappeared again. Jeroen, I'm going then for you, because in respect to the physical activity and the gender issues, for example, what is your take?
From a behavioral perspective, we know that at least in high-income countries, that men are generally more adhering to physical activity guidelines, but also are more engaged in prolonged sedentary behavior, which is in high-income countries the case because of the white-collar jobs and the office work that men are more often engaged in, at least still. I think that changes, but there is a gender inequality in behaviors as well with regard to physical activity and sedentary behavior.
We need to. And I would be curious, especially to see, in COVID, we see changes. What will happen afterwards? The more health conscious people will hopefully more, at least continue this healthier aspects they experienced during the confinement. But obviously, depending on your job, your work, etc., this will matter as well. Can I turn to the diet? And it's to Christophe, but also to the others. Christophe, you talked about anti-inflammatory foods. Now, I think, especially in the whole thing we have been discussing, from the clinical side, you need good trials, and you want evidence on a specific food, or especially a specific nutrient or component. But people eat them together in diets, in dietary patterns, as we also sometimes call them. And maybe, some of the components can enhance each other and can show synergy. What is your view on that?
Well, I think Quirijn mentions it already. I mean, there are several things. I mean, first of all, some studies are not necessarily financially supported, and in that sense, because they first require mechanistic evidence, which is sometimes difficult in diet. If we are talking about a diet, really a dietary pattern, it's sometimes very difficult. I think one of the things that we definitely have learned is that maybe better well-controlled trials, even if there would be a possibility to have, for example, feeding trials. I'm referring to some of the discussions that has been pointed out by a publication by Mike Gibney in Nature Food, and then a publication by Kevin Hall in Science, where we have very strict conditions and we really control the conditions. I think that is definitely a way to go, but still that is not necessarily covering everything, because a side remark of some of the studies of Kevin Hall, for example, it's always in a very strict control situation, but it's also very limited in time. I mean, it will be very difficult to really follow dietary patterns over a very long time, although there are some metabolic urinary markers giving some as an indications, of course. But as far as I know, and I have to look at maybe at you as Edith, as coordinator from football, those are mainly indicators of one specific food item that is highly consumed, for example, but not necessarily a whole specific dietary pattern. And so in that sense, to really increase our compliance, or to test it, to evaluate the compliance of people participating in dietary interventions, there is some, ideal marker would be incredible, and an incredible added value. And that's what you see as well with nutrition studies. Sometimes we get the negative thing of nutrition studies we don't get in high publications. Although I disagree. I mean, there was a publication of De Rever from the Netherlands on and Jaap Sedal and Martijn
sugar sweetened beverage.
The sugar sweetened. I mean, that was a very nice, well-designed study, but they had a very strict control. They had a marker identified, really collected that data, and it was published in the New England. So in that sense, I think there are possibilities, and I think there we should strengthen our efforts and maybe join our efforts as well. I'm thinking of well-controlled. In Belgium, we have the KCE, but I think in the Netherlands you have ZonMW, you have in other countries you have this and that. You have clinical dietary interventions that really combine the efforts, and that we have a lot of people to follow up, but also then very strict control trials.
Can I go, Fauzi? Maybe because I'd like to introduce the physical activity in this discussion as well. Fauzi, you already hinted upon, right? It can be different, but there can also be common pathways. So you would, maybe combine it, healthy diet with physical activity. Obviously, then this cannot be blinded, which is, sometimes, in the sense of the rule of the evidence-based medicine pyramid, we are a little bit lower on the list. But do you see opportunities there?
Yes, I fully agree with you. Well, I would like also to say that while randomized controlled trials are integrating these two dimensions of our behavior, lifestyle behavior, are important, other design like cross-sectional perspectives are also very important. I don't think there are different questions, different knowledge that can be gained with different designs. That's important. I would like to highlight 3 points in this discussion that, which I think has been highlighted during this pandemic, is that we have to consider both behavior not separately, because as you said, Edith, they can be separate paths, they can also potentiate each other. I would like also to say that it's very important that in our future studies and future efforts at European and world level, that ethnicity and geographical location are included as routine as the age and the sex in the studies, because I think this is something that future research will really gain from that, because we should have results that represent the whole community, not just part of it. We also, in terms of mechanism, because I mean there is behavior, but we have to have mechanism, and I think that including mental, physical aspects are also very important, because this is what we see now. There is there is tremendous interaction going on there, and also I think that, and this has been the second talk today, that I think from my point of view, and when I see now the studies that we are performing, we are now turning to digital tools more and more So I think that we should put more emphasis on digital tools for supporting behavioral changes, and because this is very important. And while we do this, I think it's very important that we, in such studies, that we include also biological effects, so that we deal with these digital platforms, but while having an idea that will give us valuable and important information about what is happening at the biological level. And finally, I think it's very important when we talk for physical activity. When we look at one behavior, like if you are physically active, if you do exercise or something else, we have to think that we are always actually, when we increase the amount of one behavior, we decrease the amount of the other. So it's very important then that we consider all behaviors in the same time, because if we have 13 or 12 waking hours, I mean, we have always to think, what shall I do when I increase one behavior? Of course, it will impact another behavior. So we should have also, in terms of behaviors, we should have an integrated view on the total impact of our behavioral change, and not only one part of it.
Thank you very much. In the meantime, I'd like to read Wolfgang's chat. Wolfgang, thanks very much. I better read it. He wants to highlight 3 aspects regarding the long-term research agenda, so to speak. The collateral health damage caused by the restrictions due to the consequences of the lockdown and the confinement, the social deprivation of economic insecurity. I think this is very relevant for the whole of Europe. Focus on the long-term consequences and for health conditions, not always directly related to COVID-19, but, if we have unhealthier habits or if we have rapid weight gain after COVID, what does this mean for NCDs, the diseases in the future? Persistent changes of health behavior triggered by COVID-19 crisis. For example, the effect of the digitalization on the sedentary behavior we already discussed and the physical activity, but also the effect of restrictions on the food outlets and fast food consumption, the home delivery, sometimes going up, sometimes going down. And finally, indeed, like Fauzi already indicated, the boost in the use of digital technologies. And there's a lot of security issues concerned with that. We see that also in the Netherlands with the Corona app, for example. But there are risks, yes, but also new opportunities for digital interventions that we discussed just now. This really aligns well with what other panel members already indicated. Thank you, Wolfgang. Maybe a final word to Laura. Having heard this, a view to maximum societal impact from your point of view as a chair of the SAP. Oh, yes, Jeroen, wait a minute. I come back to you. Laura?
Sorry, I didn't hear the question.
Okay, then I go first to Jeroen. Jeroen.
Yeah, so I fully agree with has been said, and also by Professor Kadi on the more focus on digital improvements. But I would also like to stress that a large role should actually be put in an even more upstream, more higher level, which is a policy where health and health behavior should have a larger voice in when policy is made with regard to urban infrastructure, but also with regard to licensing of fast food restaurants, delivery, etc. Because then you really can have an impact also to those who need it the most.
Mm-hmm. Yes, I think this is a very nice closure. Laura, you don't mind if we leave this for now? I didn't have any specific questions for you, but also wanted to have a little bit of view of the shop. But I think this is now summarized quite well. Any urgent messages from one of the panel members before I close? Everything? No additional things we forgot to address? Then I'd like to thank you very much for being present this morning and giving all your input. And we hope we will stay in touch. I know we will stay in touch, but also perhaps some additional questions will arrive by email. And also the things we've said, your slides will be used to a very great extent within the JPI HDHL. And I'd like also to thank the audience for actively participating and at least actively listening.